All right, everyone. Welcome to the nervous system. Now, if you think about it, this system is essentially the body's electrical wiring and communication network rolled into one very high maintenance package. Every movement you make, every sensation you feel, and every thought you have, all of it runs through this incredibly specialized tissue. From a histotechnology perspective, nervous tissue is fascinating because it is highly cellular, structurally delicate, and extremely unforgiving when it comes to processing artifacts. You can get away with a lot in connective tissue, but nervous tissue, not so much. We will spend time connecting structure to dysfunction because when neurons die, demyelinate, compress, or misfire, the clinical consequences are often dramatic. One thing I want you to keep in mind throughout this unit, unlike many other tissues, neurons generally do not regenerate effectively, so preservation of morphology is critical, both biologically and microscopically. A fun but slightly terrifying fact, your brain makes up about 2% of your body weight, but consumes roughly 20% of your oxygen. Talk about being metabolically needy. All right, let's build the foundation first by talking about the major cell players. Before we dive into disease, we need to know who lives here. The central nervous system is not just neurons. In fact, neurons are actually outnumbered by their support staff. Think of this like a hospital. Neurons are the physicians making decisions and sending orders. Glial cells are everyone else who keeps the place operational. And honestly, without the support staff, nothing functions. We will briefly introduce each cell type now, and then we'll see them repeatedly when we talk pathology, especially tumors and demyelinating diseases. As future histotechnologists, recognizing these cells is important because many neurological diagnoses rely heavily on subtle morphologic differences. Also, nervous tissue tends to stain beautifully when treated correctly, but poorly processed brain tissue looks like abstract art, not the good kind. Let's talk glial, the unsung heroes of the nervous tissue. Glial cells are often described as support cells, but that label undersells them quite a bit. They regulate the extracellular environment, provide insulation, participate in immune defense, and even influence signal transmission. Let's walk through them. We have astrocytes. These are the structural stabilizers. They help maintain the blood-brain barrier, regulate ion concentrations, and basically keep neurons from living in biochemical chaos. Histology tie-in is that astrocytes become very important in injury because they proliferate and form glial scars, a process called gliosis. When you see that dense fibrillary background on a slide, think astrocyte response. Then we have oligodendrocytes. These are your central nervous system myelin producers. One oligodendrocyte can myelinate multiple axons, which is incredibly efficient, like insulating several electrical wires at once. This is why diseases that destroy myelin, such as demyelinating disorders, have such widespread effects. Some worthless but fun knowledge. Myelin is about 70 to 80% lipid, which is why brain tissue has that soft, almost buttery consistency. Yes, that's your histology nerd fact for the day. Then we have ependymal cells. These line the ventricles and help circulate cerebrospinal fluid. If CSF flow is disrupted, pressure builds, and brain tissue does not appreciate being compressed. The microglia, the immune defenders, they act like macrophages, constantly surveilling for pathogens, debris, and damaged neurons. When activated, they become plump and mobile, a sign something is wrong in the neighborhood. And then the choroid plexus. This is where CSF is produced, and just as a clinical tie-in, the brain floats in CSF to reduce its effective weight from about 3 pounds to roughly 50 grams. Otherwise, we'd all be walking around with crushed brain stems. Not ideal. Now let's orient ourselves geographically, because when something goes wrong neurologically, location often predicts symptoms. The frontal lobe is the executive function, personality, and motor planning. Damage here can change behavior dramatically, sometimes more noticeable than physical deficits. Then you have the parietal lobe. that processes sensory information. If patients say, I can feel it, but I can't tell what it is, this region may be involved. The temporal lobe, this is the memory and auditory processing unit, also highly seizure-prone tissue. The occipital lobe is the visual interpretation. So eyes may work perfectly, but if this area is injured, the brain cannot interpret what it sees. And then there's cerebellum. Coordination and balance live here. Classic dysfunction produces that unsteady, almost intoxicated gait. Brainstem. This is possibly the most life-critical real estate in the body. It controls respiration, heart rate, and consciousness. Very small area, but very big consequences. Histotech connection. Different brain regions have distinct cellular architecture, vary in neuron densities, white to gray matter ratios, and vascular patterns. So orientation during embedding and sectioning matters. A poorly oriented brain specimen can make localization extremely difficult for the pathologist. In neuropathology, millimeters matter greatly. All right, let's talk about the brainstem, also known as the structure you should thank every day for keeping you alive, without you having to think about it. The brainstem connects the brain to the spinal cord and is made up of three main regions: the midbrain, the pons, and the medulla. Think of it as the body's automatic life support control center. Heart rate, breathing, blood pressure, reflexes like coughing or vomiting, they are all handled here. No pressure, brainstem. You're just responsible for survival. Histotechnology connection. From a tissue standpoint, the brainstem is packed with ascending and descending tracts, nuclei, and reticular formation structures. When processing this tissue, orientation matters, because a few millimeters off can completely change what structure you're evaluating. Also worth noting, the neurons here don't regenerate well, so when injury occurs, stroke, hemorrhage, or herniation, the damage is often catastrophic. A fun but slightly terrifying fact, damage to the medulla can stop breathing almost immediately, which is why swelling in the brain is such a big deal clinically. Tiny structure, but massive consequences. Now let's move into the cranial nerves, 12 pairs that emerge directly from the brain rather than the spinal cord. And yes, students everywhere try to memorize them with questionable mnemonics. I'll spare you those. Instead, focus on function. Some are pure sensory, like smell and vision, pure motor, or mixed. Why do histotechnologists care? Because cranial nerve dysfunction often points clinicians toward very specific lesion locations. For example, facial drooping, think facial nerve. Hearing or balance issues, think vestibulocochlear. Difficulty swallowing, think glazopharyngeal. Or vagus. When tissue is submitted from areas near nerve pathways, tumors, inflammatory lesions, and demyelinating diseases, understanding what runs through that region helps everything make more sense. Some worthless but delightful knowledge. The vagus nerve wanders extensively through the thorax and abdomen. Vagus literally means wandering. Honestly, relatable. Now let's talk about the ventricular system, the brain's internal plumbing. These interconnected cavities produce and circulate cerebrospinal fluid, or CSF. We've got two lateral ventricles, a third ventricle, and a cerebral aqueduct, also a fourth ventricle. So CFS flows through these spaces and eventually surrounds the brain and spinal cord. The function of CSF, it cushions the brain, it provides nutrients, it removes waste, and it helps maintain pressure balance. So basically, it's shock absorption plus housekeeping. Histology tie-in, remember the choroid plexus from earlier? Well, this is where CSF is produced. It's lined by specialized ependymal cells with tight junctions forming the blood-CSF barrier. Tumors here are rare, but fascinating under the microscope. If CSF flow is blocked, you get hydrocephalus, which means enlarged ventricles and compression of brain tissue. And brain tissue does not appreciate being compressed. Your brain weighs about 3 pounds, but again floats in CSF, reducing its effective weight dramatically. Otherwise, the base of your brain would literally crush under its own mass. Again, engineering at its finest. Now let's wrap this section with the meninges, the protective layers surrounding the CNS. Think of them as the brain's security system. From outermost to innermost, we have the dura mater, which is tough and fibrous. We have the arachnoid matter, which is delicate and web-like. We have the pia mater, which is thin and intimately adherent to brain tissue. If the dura is leather, the pia is plastic wrap. Each layer has distinct structural characteristics: dense connective tissue in the dura, trabecular architecture in the arachnoid, and highly vascular pia. When inflammation hits these layers, hello meningitis. The changes can often be appreciated microscopically, depending on severity and thinning. Also important, subdural and epidural hematomas occur in different anatomical spaces, which directly impacts both imaging interpretation and surgical urgency. Some worthless knowledge you'll now never forget. The brainstem itself has no pain receptors. The brain itself has no pain receptors. Headaches usually come from irritation of the meninges or blood vessels, not the brain tissue. So technically, your brain cannot feel pain about your life choices. Only the meninges can. All right, let's orient ourselves first because this is not just a brain sitting here. What we are looking at is the inner surface of the skull cap, with the dura mater still attached, and this large dark collection is a subdural hematoma. So let's break that down. A subdural hematoma is bleeding that occurs between the dura mater and the arachnoid mater, most commonly due to tearing of the bridging veins. These veins are vulnerable because they stretch from the brain surface to the dural sinuses, and stretching forces, especially rotational injuries, can shear them. This is why subdurals are frequently associated with falls, motor vehicle accidents, shaken brain injuries, or elderly patients with cerebral atrophy. Less brain volume equals more vein tension. Now, visually notice how this blood spreads. It forms a crescent-shaped collection conforming to the contour of the skull. That shape matters diagnostically, and yes, radiologists love that crescent. Even though this is gross pathology, it directly impacts what eventually lands in your cassette. When subdural hematomas organize, you may see fibroblast proliferation, neomembrane formation, hemosiderin-laden macrophages, or chronic inflammatory cells. In chronic cases, the membrane can even develop fragile capillaries, setting the patient up for rebleeding. The brain is not a fan of stability. Clotting blood can be deceptively firm on the outside but gelatinous internally. When sections are submitted, ensure adequate fixation before processing. Expect variability in texture, and slow processing prevents artifact. Brain-adjacent tissue is never the place to rush. Subdurals are often slower bleeds than epidural hematomas, which means symptoms may be subtle at first, so headache, confusion, personality change, and gradual neurologic decline. And this is why they can be especially dangerous in older adults. The presentation is easy to dismiss. Worthless knowledge that is actually useful. The dura mater is called dura for a reason. It literally means tough mother, and it lives up to the name. It is dense, fibrous, and remarkably protective. Unfortunately, when bleeding happens beneath it, that toughness also means there is nowhere for the pressure to go. So rigid skull plus expanding blood equals rising intracranial pressure. Never a good equation. Now this is one of those images students never forget. What you are seeing here is a large intracranial hemorrhage, dark, space-occupying, and catastrophic. Let's connect structure to consequence. The skull is a rigid box. There is no extra room. So when bleeding occurs, pressure rises rapidly, compressing adjacent brain tissue, disrupting perfusion, and potentially causing herniation. From the histology side, hemorrhage evolves in recognizable stages. So early stages, we have intact red blood cells. Intermediate stages will have macrophages arrive, and then the later stages, hemosiderin deposition, and eventually gliosis. If you remember nothing else, remember this. Blood is irritating to neural tissue, very irritating, which is why even small bleeds can have very major neurologic consequences. Hemorrhagic tissue loves to create processing challenges, especially incomplete fixation and microtomy chatter. Slowing down your processing schedule often saves your sanity. And fun fact, the brain consumes about 20% of the body's oxygen despite only being roughly 2% of the body weight. So high demand plus delicate tissue equals very low tolerance for vascular events. Now let's talk about how the brain gets its lifeline, its blood flow. This diagram shows the major arterial contributors, but here's the clinical takeaway I want you to anchor to. Different arteries supply different functional territories, meaning when a vessel is blocked, symptoms are often predictable. For example, middle cerebral artery compromise, think motor and speech deficits. Posterior circulation, think vision and coordination. You do not need to memorize vascular maps, but you should understand that perfusion patterns explain lesion patterns, because later, when you see localized necrosis on a slide, you'll know it wasn't random, it was vascular. A histology tie-in, ischemic brain injury typically produces liquefactive necrosis, which looks dramatically different from infarcts in solid organs like the heart. The brain doesn't scar the same way. It softens, it cavitates, and it remodels with glial cells instead of fibrous tissue. And yes, we will absolutely revisit that. Some worthless but interesting knowledge: neurons can begin suffering irreversible injury after roughly 4 to 6 minutes without oxygen. Your brain is incredibly powerful, but also incredibly fragile. If the brain were designing a backup generator, this would be it. The circle of Willis is an arterial ring that provides collateral circulation. In theory, if one vessel narrows slowly, alternate routes can compensate. Keyword: slowly. Sudden occlusion rarely gives the circle enough time to help. Now, here is something many students don't realize. A perfect circle of Willis is actually uncommon. Anatomical variation is the norm, which explains why two patients with similar vascular disease can have very different outcomes. From a pathology standpoint, this region is also notorious for Berry aneurysms, small balloon-like outpouchings that can rupture and cause subarachnoid hemorrhage. And if you ever see meninges coated in blood on a gross specimen, you will never forget it. Histotech consideration here is that aneurysm-associated hemorrhage often produces delicate friable tissue. Gentle handling during embedding is not optional. Treat brain tissue like the diva it is, because it absolutely is. And fun fact, Thomas Willis, the physician who described this structure, was doing microanatomy in the 1600s. Imagine mapping cerebral arteries without modern imaging. We complain about microtome blades. He didn't even have electricity. Perspective. All right, let's look at this specimen. What you see here is a coronal section of brain demonstrating a large intracerebral hemorrhage, most likely involving the basal ganglia region, a very common site for hypertensive bleeds. Notice how the hemorrhage is dark red to almost black, well demarcated, and compressing surrounding tissue. That compression is not just a structural issue, it is a perfusion issue. Brain tissue does not tolerate pressure well. Unlike muscle or skin, it has almost zero extra space. Remember the rule: blood where it shouldn't be equals tissue death. When this comes to the lab, your fixation matters immensely. Hemorrhagic brain tissue is extremely soft, friable, and easy to artifact. If underfixed, you will get tissue tearing, poor microtomy, nuclear smudging, and loss of architecture. Pro tip: brain should fix longer than you think it needs to. Patience here saves you from a microtomy nightmare later. Worthless knowledge, but is actually kind of useful. The basal ganglia are sometimes called the stroke sweet spot, not because it's good, but because chronic hypertension weakens the tiny penetrating arteries here. Tiny vessel plus high pressure equals rupture risk. Plumbing rules apply to humans too. Okay. Let's simplify stroke into two major buckets. Ischemic stroke, which is blocked pipe, about 85% of strokes. Sometimes something obstructs blood flow, such as a thrombus or an embolus or severe atherosclerosis. So no oxygen creates ATP depletion, which creates an ion pump failure that causes swelling and then later necrosis. The brain basically enters an energetic bankruptcy. Then there's hemorrhagic stroke, which this is a pipe burst stroke. Less common, but often more immediately catastrophic. Blood escapes the vessel and begins destroying tissue mechanically and chemically. Blood breakdown products are irritating to neurons, and neurons are drama queens. They do not handle stress well. Ischemic infarcts evolve over time. So early on, we'd see red neurons. Later on, we'd see macrophages, and then eventually cystic spaces. Hemorrhagic areas, you'll see red blood cell infiltration, hemosiderin-laden macrophages, and reactive gliosis. And yes, brain sections with old hemorrhage often cut better than fresh ones. Clotted blood has structure. Fresh bleed is just chaos. Traumatic brain injuries are physics in action. A coup injury occurs at the site of impact. A contra-coup injury occurs on the opposite side when the brain rebounds inside the skull. Think of the brain like very expensive gelatin. Rapid deceleration equals slosh. Why this matters clinically? Patients don't always show deficits where you expect. Hit from the front, there may be damage to the back. Fall backward, you injure the frontal lobes. This is why mechanism of injury is so critical in pathology review. From a histotech angle, traumatic injuries often produce petechial hemorrhages, diffuse axonal injury, microvascular damage, and DAI especially is a microscopic diagnosis. Gross exam may look deceptively mild, and silver stains or immunostains like beta amyloid precursor protein may be used to highlight axonal damage. Translation: sometimes the slide tells the real story, not the gross. Fun fact, the brain moves about 1 centimeter inside the skull during high force trauma. Doesn't sound like much until you remember neurons are measured in microns. Now this is a classic high velocity injury pattern. Notice the scattered hemorrhagic foci, particularly near the gray-white junction. That location is key. Why there? Because tissues of different densities accelerate at different speeds. Gray matter and white matter do not move together nicely during rotational injury. The result? Shearing forces, axonal tearing, and instant communication breakdown. It is literally a wiring failure. DAI is one of the most common causes of immediate unconsciousness, persistent vegetative state, and severe traumatic brain injury outcomes. And sometimes the CT scan early on looks underwhelming. Again, microscopy often reveals the severity. Pathology humbles everyone. Brain trauma tissue can be tricky. It can be edematous, structurally fragile, prone to chatter during cutting. And so what you need to do is slow your microtomy, use a sharp blade and a very cold block, and always respect the brain. Again, always respect the brain. Worthless knowledge that is actually fascinating. The force required to produce severe DAI is comparable to what occurs in many high-speed car crashes, which is why helmet technology is constantly evolving, especially to reduce rotational forces, not just direct impact. Linear protection isn't enough. Brains hate twisting. All right, let's orient ourselves here. What we're looking at here is a coronal section of brain with a large intracerebral hemorrhage occupying the right hemisphere. Notice how dark and space occupying that clot is. Blood does not belong in brain parenchyma, and when it shows up, it behaves like an extremely rude house guest. It pushes, it compresses, and it destroys nearby neurons simply by existing. Most spontaneous intracerebral hemorrhages are linked to chronic hypertension, vessel wall degeneration, and microaneurysm rupture, which is Charcot-Bouchard aneurysms, which is excellent, worthless knowledge. Once the vessel ruptures, blood dissects through tissue planes, and then increases intracranial pressure, which reduces perfusion and then causes secondary ischemic injury. So even areas that are not bleeding can still die. Very dramatic, very inefficient, but very brain-like. Hemorrhagic brain tissue is soft, friable, and extremely easy to artifact. I cannot say that enough. Gentle handling matters. Overfixation does not fix sloppy grossing. Remember that. Also expect macrophages cleaning up the hemoglobin, hemosiderin deposition, and reactive gliosis. The brain always tries to wall off chaos, sometimes successfully, sometimes not so much. All right, let's simplify stroke into two major buckets as we did before. Ischemic stroke, aka the nothing is getting through stroke, usually caused by thrombus, embolus, and severe atherosclerosis. No oxygen equals ATP depletion equals ion pump failure. Then we go into cytotoxic edema and then neuronal death. Neurons are metabolically needy little divas. 3 to 5 minutes without oxygen and they start filling their resignation paperwork. Hemorrhagic stroke, aka the plumbing failure. Here we'd see vessels rupture, blood floods tissue, the pressure rises, perfusion drops. Interestingly, hemorrhagic strokes often look more dramatic on imaging and gross exam, but ischemic strokes are far more common. Histology timing fun fact, 12 to 24 hours you have red neurons appear. So shrunken, intense eosinophilic, and pathologists love spotting these. 48 to 72 hours, the neutrophils arrive. Always late, always dramatic. And then days, weeks, we have macrophages and gliosis. Eventually, cystic cavity. Brain healing is less repair and more cleanup and move on. This is one of my favorite neuropath concepts because physics explains pathology beautifully. Coupe injury occurs directly beneath the site of impact, so the brain hits the skull and it results in bruising. Simple enough. Contra-coupe injury, the brain rebounds and slams into the opposite side. Because remember, your brain is floating in CSF, not tightly packed, so it moves. Rapid deceleration equals rotational forces plus shearing. And neurons do not tolerate shear well. Axons stretch, then tear, and then disconnect. This is why traumatic brain injuries can produce widespread neurological deficits, even when the external injury looks minor. A histotech connection is that diffuse axonal injury is often subtle grossly, but devastating microscopically. Silver stains or immunostains may highlight damaged axons, depending on your lab protocols. Also worth noting, the frontal and temporal lobes are frequent victims. Why? Lots of bony ridges inside the skull. Nature did not sand those down for us. How rude. Whenever you see serial brain slices like this, your brain, pun fully intended, should switch into pattern recognition mode. Ask yourself, is the injury focal or diffuse? Gray matter or white matter? Symmetric or asymmetric? Those questions guide interpretation fast. These sections suggest widespread injury, possibly hypoxic, toxic, or metabolic depending on the clinical story. Remember, the brain has selectively vulnerable regions, including the hippocampus, the Purkinje cells of the cerebellum, the watershed zones, and cells with high metabolic demand are always first to fail. Much like me before coffee. Histology expectations. With global hypoxia, you may see red neurons, tissue pallor, and loss of normal architecture. Later on, you may see macrophage infiltration and eventually cystic change. Brain scars differently than most organs. No fibrotic heroics here, just tissue loss. Some worthless knowledge, and I've said this again, but I'll say it again because I wrote it here for the third time. Your brain makes up about 2% of body weight, but consumes roughly 20% of your oxygen. High maintenance organ, but admittedly kind of important. All right, friends, this is one of these drop everything and pay attention pathology moments. Brain herniation is what happens when intracranial pressure rises high enough that brain tissue is physically displaced from one compartment to another. And remember, the skull is not stretchy. There is zero extra real estate in there. So when something expands, either via hemorrhage, tumor, or edema, the brain has only one option: push somewhere else. Think of it like trying to overpack a carry-on suitcase. Eventually, the zipper gives. except here the zipper is the brainstem, and that is very bad for business. So types shown here, we have the subfalcine herniation. This is cingulate iris pushed under the falx. It can compress the anterior cerebral artery and leads to ischemia. Transtentorial or uncall herniation. The temporal lobe pushes downward. It compresses our cranial nerve 3. Classic clinical clue, we have a blown pupil. When you hear that, think uncall herniation immediately. Then there's the tonsillar herniation. Cerebellar tonsils force through the foramen magnum. It compresses the medulla, which controls breathing and cardiac function. Translation: incompatible with life if not reversed immediately. Histotech Pearl. When examining brain tissue from herniation cases, you may see compression necrosis, ischemic change, direct hemorrhages in the brainstem, and yes, these are Board's level associations. Worthless knowledge: the brain only needs about 5 minutes without oxygen before irreversible injury begins, so herniation is not a slow drama, it is a medical sprint. This is the classic head snap backward mechanism. Common causes: rear end collisions, falls, contact sports, and basically any situation where physics wins. Hyperextension can injure cervical vertebrae, ligaments, the spinal cord, and vertebral arteries. One particularly nasty injury associated with hyperextension is central cord syndrome, where the upper extremities are more affected than the lower. Why? Because cervical fibers controlling the arms sit more centrally. Histology tie-in: you may see axonal swelling, hemorrhage, edema, and myelin disruption. Not things we enjoy embedding, just saying. Clinical Pearl: older adults are especially vulnerable due to degenerative spine changes. And then a fun-ish fact: your neck muscles are strong, but your brain weighs about 3 pounds, which becomes a wrecking ball during rapid acceleration. Physics does not negotiate. Now we go the opposite direction, head forced forward violently. Think head-on collisions, diving accidents, and sudden deceleration. Hyperflexion often produces anterior compression fractures or worse, burst fractures, where bone fragments can retropulse into the spinal cord, which is exactly as bad as it sounds. Spinal cord consequences to this are contusion, laceration, and complete transection. And unlike many tissues, neurons do not regenerate well. Neuroglia try, bless them. Histotech angle: expect to recognize hemorrhagic necrosis, white matter tract damage, and macrophage cleanup clues. Clinical correlation: we'd see loss of motor and sensory function below the lesion. Remember, level matters. C3 to C5 injury, you stop worrying about the diagram. C3, 4, and 5, keep the diagram alive. Tiny humor moment: the spinal cord is basically the body's fiber optic cable. Sever the cable, the signal drops. No Wi-Fi reboot available. All right, let's orient ourselves from inside out. Pia mater, arachnoid, subarachnoid space, hello CSF, dura mater. Same protective theme as the brain, just in a long cylindrical format. Key structures to recognize: gray matter is butterfly shaped. Neuron cell bodies we'll see. The white matter has myelinated tracts. It's the information highways. The central canal is the CSF pathway. Sensory root ganglion houses sensory neuron cell bodies. It's very recognizable histologically. Clinical tie-ins: epidermal hematoma, often arterial in rapid progression. Subdural would be venous and can be slower. Subarachnoid hemorrhage is the worst headache of my life. Never ignore that phrase. Histotech reminder: the spinal cord tissue is soft and highly lipid rich, meaning fixation matters tremendously. Poor fixation equals artifact city, and nobody wants to diagnose artifact. Worthless knowledge: if you stretched out the spinal cord, it would only be about 18 inches long, yet it manages communication for your entire body. That's classic overachiever behavior. All right, this is one of those slides that looks deceptively simple until someone asks it on an exam. Let's walk through it. The dorsal root carries sensory or afferent fibers into the spinal cord. Think dorsal equals detex. The ventral root carries motor or efferent fibers out to muscles. So ventral equals vroom or movement. Once those roots merge, you get a mixed spinal nerve, meaning it contains both sensory and motor fibers. Then it splits again into the dorsal ramus, which supplies the back muscles and skin, or the ventral ramus, which supplies the limbs and anterior body, aka the areas patients complain about most. Now, quick histotech connection. If you ever process peripheral nerve tissue, remember, white rami equals myelinated sympathetic fibers. Gray rami equals unmyelinated fibers. Translation, white equals fast, gray equals slower. Much like faculty email responses during accreditation season. Spina bifida results from failure of the neural tube to close, typically around week 4 of development, often before a woman even knows she is pregnant. Spina bifida occulta is the mildest form, and the vertebral defect is only. The spinal cord is normal, so often discovered incidentally. Sometimes there is a little tuft of hair over the defect, nature's weirdest bookmark. Then there's meningeocele. The meninges herniate through the defect, the cord remains in place, has a better prognosis. Then we have a myelomeningocele. This is the big one. Cord and meninges protrude. Severe neurological deficits, often associated with the Chiari-2 malformation. Clinically important point, folic acid supplementation dramatically reduces risk. Histology tie-in, you may see disorganized neural tissue, gliosis, and malformed meninges depending on severity. Remember, oculata is hidden, meningeocele is membranes, and myelomeningocele is everything decides to leave the building. This is one of the most severe neural tube defects. Anencephaly occurs when the rostral neural tube fails to close, leading to absence of a large portion of the brain, particularly the cerebrum. These infacts lack higher brain function and are typically not compatible with long-term survival. Pathologically, you see absence of cranial vault, rudimentary brain tissue, and exposure to amniotic fluid, which results in degeneration. Prevention again comes back to folic acid. Neural tube closes between days 21 to 28, so when we say prenatal vitamins matter early, we mean early. Also, this is why public health policies fortify grains with folate. Sometimes pathology isn't just science, it's prevention. This image demonstrates an extreme failure of neural tube closure involving both the brain and the spinal cord. This is called craniorachisis. Try saying that 3 times fast before coffee. It results in open brain, open spinal cord, severe neurologic maldevelopment. It is uniformly fatal. From a developmental standpoint, this reflects a complete failure of neurulation. Histologically, you would expect poorly formed neural tissue, absence of protective meninges, and massive structural disorganization. Clinical pearl, again, strongly linked to folate deficiency. If there were ever a vitamin deserving of a superhero cape, it's folic acid. Quick terminology check before we go deeper. Let's start with myelitis, which simply means inflammation of the spinal cord. But don't let the simplicity of that definition fool you. Inflammation inside the spinal cord is a very big deal because there is very little extra space. When swelling occurs, neurons get compressed, conduction slows, and patients can rapidly develop weakness or even paralysis. From a histology perspective, you would expect to see inflammatory infiltrates, edema, and sometimes demyelination depending on the cause. Next is encephalitis, inflammation of the brain itself. Most commonly viral, think HSV, arboroviruses, things that like to crash the neurological party. Microscopically, classic findings include perivascular cuffing, microglial nodules, and neuronophagia, which sounds dramatic because it is, neurons literally being eaten. Fun fact, microglia are basically the brain's resident immune cells. Think of them as tiny, grumpy custodians that immediately show up when something goes wrong. Now, cerebral abscess. This is a localized collection of pus within brain tissue, meaning liquefactive necrosis has entered the chat. Histologically, you often see central necrotic debris, tons of neutrophils, a developing fibrotic capsule. And here's the clinical twist. Once a capsule forms, antibiotics have a harder time penetrating, which is why some abscesses require surgical draining. Some worthless knowledge moment here. The brain is one of the few organs where liquefactive necrosis is the default pathway after injury. Everywhere else tries to hold structure together. The brain just dissolves into enzymatic soup. Comforting, right? Let's talk about a bacterium that believes in the long game. Treponema pallidum, a spherochaete responsible for syphilis, can quietly hang out in the body for decades if untreated. And years later, surprise, neurosyphilis. This organism is thin, corkscrew-shaped, and notoriously hard to see with routine stains. This is why special techniques like silver stains or dark field microscopy are often used. Histologically, neurosyphilis can produce chronic inflammation, meningiovascular changes, cortical atrophy, and gummas, which are granulomatous lesions. One classic late finding is tabes dorsalis, where degeneration of the dorsal columns leads to sensory ataxia. Translation: the brain knows where the body is supposed to be, but the signal never arrives. Fun fact: before antibiotics, neurosyphilis was one of the most common causes of dementia in the U.S. Also, and this is wild, physicians once intentionally infected patients with malaria to create high fevers that killed the spherochaetes. It was called malarial therapy, and it actually won a Nobel Prize. Medicine has come such a long way. Meningitis is one of those diagnoses where time matters a lot. Let's walk through the usual suspects. E. coli, primarily in neonates, often acquired during birth. Then we have Haemophilus influenzae, thankfully less common now due to vaccination, which is one of public health's biggest success stories. Then there's Neisseria meningitis, the college dorm nightmare. Gram-negative diplococci, that's spread through respiratory droplets. And then finally, Streptococcus pneumoniae, which is one of the most common causes in adults. Histologically, bacterial meningitis produces a purulent exudate within the subarachnoid space. So when you process these tissues, you may see dense neutrophilic infiltrates, fibrin, thickened meninges, and if severe, inflammation can extend into cortical tissue, leading to cerebritis. Histotech tip: these specimens can be very delicate and often edematous. Gentle handling during grossing and careful processing helps preserve meningeal architecture. Some worthless knowledge: the subarachnoid space normally holds CSF, which is crystal clear. In meningitis, it can become cloudy enough that clinicians describe it as looking like skim milk. Not a mental image you wanted, but memorable nonetheless. Now we move into one of the strangest topics in all of pathology, prions. Not bacteria, not viruses, not fungi, just misfolded proteins. Imagine a protein that folds incorrectly and then convinces every normal protein nearby to also fold incorrectly. It's basically the pathological version of peer pressure. These abnormal proteins resist degradation and accumulate inside neural tissue, producing the classic spongiform appearance. Tiny vacuoles throughout the gray matter. Under the microscope, the brain literally starts to look sponge-like. No inflammation, no immune response, which is part of what makes prion diseases so unsettling. The body barely recognizes the threat. Examples include the Creutzfeldt-Jakob disease, variant CJD, or KURU. Fun but slightly disturbing fact, prions are incredibly resistant to standard sterilization. Even autoclaving may not fully inactivate them. So yes, they make infection control professionals very nervous. Histology Pearl. Because neurons are primarily affected, you'll see progressive neuronal loss with reactive gliosis. Another reminder that when neurons die, they do not regenerate. The nervous system does not believe in second chances. All right. So we've already kind of described prion disease, and so yes, it is otherwise known as the infamous mad cow disease connection. We have variant Creutzfeldt-Jakob disease has been linked to bovine spongiform encephalopathy, or BSE, meaning transmission likely occurred through ingestion of contaminated beef products. Let me translate that into pathology language. A misfolded protein enters the body. That protein convinces other normal proteins to misfold. Those proteins accumulate. Neurons die. The brain develops microscopic holes, which gives us the term spongiform encephalopathy, literally meaning the brain begins to resemble a sponge. Not exactly the aesthetic we're going for. On H&E, you'll see vacuolization of the neuropil, neuronal loss, reactive gliosis, but no significant inflammation. And that last one is important. Your immune system basically looks at this disaster and goes, I do not know what that is. Because prions are not bacteria, they are not viruses, and again, they are not fungi. Just protein behaving badly. Prions are incredibly resistant to destruction again, so standard formalin fixation is not enough. Routine autoclaving, also not enough. That is why suspected prion tissue often requires extended fixation protocols or special decontamination procedures. Translation, this is one of the few times pathology says, maybe don't touch that. Now look closely at this tissue. See all those empty circular spaces? That is spongiform degeneration. It almost looks like Swiss cheese or bubble wrap, or tissue that lost a fight with a punch hole. What you're actually seeing is neuronal vacuolization, resulting from prion accumulation and neurodegeneration. Key features to recognize are the microvacuoles in the gray matter, neuronal loss, minimal inflammatory response, and astrocytosis. And remember, neurons don't regenerate well, so once this process starts, it is relentlessly progressive. Histotech Pearl, these vacuoles are not fixation artifact. Always the histotech's first suspicion, right? Instead, they are true pathologic spaces. So if you ever see widespread vacuolization in neural tissue, your differential diagnosis brain should perk up immediately. Here we have another example, slightly different stain appearance, but the same destructive process. Notice how the architecture is basically dissolving. The brain depends on highly organized neuronal networks. Prion disease turns that organization into chaos. Think of it like removing random support beams from a building. Eventually, it collapses. Clinical correlation, the patients often develop rapid dementia, behavioral changes, loss of coordination, and myoclonus, and unlike many neurodegenerative diseases, this one progresses fast. Some worthless knowledge, prion diseases can occur in multiple species. Sheep is known as scrappy, deer and elk is known as chronic wasting disease, cattle is BSE, and humans CJD. So yes, pathology is truly a cross-species adventure. Now shifting gears from rogue proteins to a virus that absolutely loves neural tissue. The herpes simplex virus, or HSV, is one of the most common causes of sporadic fatal encephalitis, and it has a favorite hangout spot, the temporal lobes, which is why patients often present with personality changes, hallucinations, and memory disruption, basically anything tied to limbic system function. Histologic hallmark is the Caudry type A intranuclear inclusions. Let's describe them like histotechs. Eosinophilic nuclear inclusions. The chromatin is pushed to the margin, and nuclear clearing. Once you see one, you never unsee it. They're the pathology equivalent of a flashing neon sign that says, viral takeover occurred here. Histotech tip: if encephalitis is suspected, you may see orders for immunohistochemistry, PCR, or molecular testing, because sometimes morphology gives us the clue, but modern diagnostics confirm the culprit. Mild humor: HSV is basically that unwanted house guest. It shows up uninvited, moves into your neurons, and refuses to leave. It causes chaos. Again, how rude. Let's talk about one of the most feared viruses in medicine, and honestly, one of the most fascinating from a neuropathology standpoint. Rabies is typically transmitted through the bite of an infected mammal. Classically, wild animals like bats, raccoons, foxes, and yes, sometimes dogs, depending on geographic region. What makes rabies particularly sinister is how it travels. Instead of jumping straight into the bloodstream like many pathogens, rabies hijacks peripheral nerves and rides retrograde transport straight to the central nervous system, essentially catching the neuronal equivalent of a high-speed train. Once in the brain, we see widespread neuronal degeneration, especially in the hippocampus and the Purkinje cells of the cerebellum. Now, histology pearl, the diagnostic hallmark is the Nigri body. These are eosinophilic cytoplasmic inclusions found inside neurons. Think of them as little viral replication factories. Microscopic proof that the virus has set up shop. Rabies is one of the very few infectious diseases where clinical symptoms almost always appear after the virus has already reached the brain, which is why post-exposure treatment must happen early. Your immune system basically gets one shot at stopping it before the neuronal express train departs. All right, histotechnologists, this is your microscope moment. Negri bodies appear as round to oval, intensely acidophilic inclusions within the cytoplasm of infected neurons, most commonly found in the hippocampus or the cerebellar Purkinje cells. On H&E, they often look like pink marble dropped into the neuron. Once you see one, you don't forget it. When scanning brain tissue with suspected viral encephalitis, your eyes should naturally move toward neuronal morphology, inclusion bodies, and inflammatory background. Negri bodies are not subtle, but you do have to slow down enough to notice them. And remember, not every infected neuron will contain one. Absence does not equal absence of disease. And some worthless knowledge you didn't ask for? They're named after Aldacci Negri, an Italian pathologist who described them in 1903 and initially believed they were protozoa. Science is humbling. Fungal infections typically fall into the category of opportunistic troublemakers. They love hosts with weakened immune systems. They transplant patients, uncontrolled diabetics, individuals on chemotherapy, etc. Let's quickly histo-walk through the usual suspects. We have Candida, often shows budding yeast and pseudohyphae. Special stains that make your life easier are going to be the GMS or Gros-Cot methionine silver, where the fungi turn black. The PAS, the fungi pop magenta. Honestly, fungi on GMS look like tiny ink drawings. Very satisfying. There's Aspergillus. We'll see septate hyphae with acute angle branching, so approximately 45 degrees. If you remember nothing else, remember the angle. Pathologists love angles. Then there's Cryptococcus. This one has a thick polysaccharide capsule, but appreciated with the mucicarmine stain, so the capsule turns a bright red. Also creates a soap bubble appearance in brain tissue due to minimal inflammatory response. The organism basically floats around like it owns the place. Then Mucor, big, broad, ribbon-like hyphae. Key distinction is non-septate with 90-degree branching. Mucor also invades blood vessels, leading to thrombosis and tissue necrosis, which is why infections can progress terrifyingly fast. Fun fact, mucormycosis is sometimes nicknamed the black fungus because of the tissue necrosis it causes, not because the organism itself is black. That's a marketing problem, quite honestly. If fungi are opportunists, Toxoplasma is a stealth operator. This protozoan has a strong preference for the gray-white junction of the cerebral cortex, an area already vulnerable due to vascular transitions. Histologically, you often see necrotizing abscesses, mixed inflammation, and tachyzoites, active form, or bradiozoite cysts. These cysts can persist quietly for years. Think of them as microscopic squatters. Transmission and why your OB colleagues never stop talking about it? Well, primary routes include undercooked meat, exposure to cat feces, especially litter boxes. Before cat lovers panic, the highest shedding occurs in young cats, not typically your pampered indoor adult feline. So don't go blame Mr. Whiskers prematurely. When you see ring-enhancing lesions on imaging, yes, we peek at radiology sometimes. Toxoplasmosis is high on the differential in immunocompromised patients. Your job at the scope? Find the organisms hiding within necrotic zones. Approximately 30 to 50% of the global population has been exposed to toxoplasma. Most never know, so sleep well tonight. Let's talk about HIV in the brain, because unfortunately HIV is not content staying politely in the bloodstream. HIV encephalitis is best thought of as a chronic inflammatory process, but it behaves a little differently than many infections we've discussed. Instead of causing massive neutrophilic infiltration or obvious abscesses, HIV tends to create a smoldering, ongoing immune activation inside the central nervous system. Histologically, what are you looking for? Well, microglial nodules, so clusters of activated microglia responding to infected cells. Multinucleated giant cells that are formed when infected macrophages fuse together. These are very characteristic. White matter pallor reflecting myelin damage. Now here is something important from a histotechnology perspective. The virus itself is not directly infecting neurons in most cases. It primarily infects macrophages and microglia, but neurons still suffer collateral damage. Think of it like living next door to someone who throws nightly house parties. You aren't the problem, but you are definitely losing sleep. Clinically, this contributes to HIV-associated dementia, which we now see less frequently thanks to antiretroviral therapy, but it absolutely still exists. Microglia make up about 10 to 15% of all brain cells, yet most people outside neuroscience have never heard of them. They are basically the brain's resident security guards. Multiple sclerosis, aka the immune system forgetting what team it plays for. MS is an autoimmune demyelinating disease of the central nervous system. The immune system targets oligodendrocytes, which means myelin gets destroyed. And when myelin goes, signal conduction slows down dramatically. Imagine trying to stream Netflix on dial-up internet. Technically possible, but emotionally devastating. Histologic features: look for plaques, sharply defined areas of demyelination. Early plaques, you'll see lots of macrophages actively chewing up myelin. Perivascular lymphocytes. For chronic plaques, you'll see gliosis, axonal loss, and firm gray-tan lesions grossly. A fun histotech note: these lesions are much easier to appreciate with Luxol Fast Blue, since H&E can make subtle demyelination harder to recognize. Another key concept: remission and relapse. Inflammation flares and the symptoms worsen. Inflammation cools and partial recovery happens, but repeated injury leads to permanent deficits. Fun fact: MS lesions often form around ventricles, producing the classic radiologic pattern called Dawson's fingers, which frankly sounds adorable for something that is not adorable at all. Now we shift gears from inflammatory to degenerative processes. These diseases share one big theme: progressive neuronal loss. Not sudden, not explosive, just slow disappearance, which is what makes them so devastating. The major players you'll hear about forever: Alzheimer's disease, Parkinson's disease, Huntington disease, and ALS. Each targets different neuron populations, but the mechanism often involves misfolded proteins. Yes, proteins misbehaving again. If pathology has taught us anything, it's that proteins are dramatic. Histologically, many neurodegenerative diseases show protein aggregates, inclusion bodies, gliosis, and brain atrophy. From a processing standpoint, brain tissue for these cases is often handled with extra care because subtle architect matters. This is not the time for rough microtomy. Treat those ribbons gently like they are made of expensive silk. Some worthless knowledge: your brain loses about 5% of its volume per decade after age 40, even without disease. So if you forget where you parked, totally normal, probably. The heavyweight champion of neurodegeneration, Alzheimer's disease is the most common cause of dementia, and pathologically it is beautifully and tragically distinctive. Some gross findings is diffuse cortical atrophy, some narrowed gyri, widened sulci, and enlarged ventricles, so hydrocephalus ex vacuo. Translation: when neurons die, the brain shrinks, and the CSF space expands to fill the gap. Nature hates empty space. Microscopic hallmarks we'll see are neuritic or senile plaques, which are extracellular deposits of beta amyloid. We see neurofibrillary tangles, which are intracellular twisted tau protein. If plaques are trash piles outside the neuron, tangles are the neuron's internal wiring collapsing. Neither is ideal. A helpful histotech reminder here are that silver stains historically highlighted these structures beautifully, though immunohistochemistry is now widely used. Also, distribution matters. Damage begins in the hippocampus, which explains why memory loss is the earliest symptom. You can't store new memories when the filing cabinet is breaking. Fun fact: Eloise Alzheimer described this disease in 1906 after examining the brain of a woman with severe memory impairment. Over a century later, we are still trying to fully outsmart it. Pathology is humbling like that. All right. So welcome to one of the microscopic hallmarks of the Alzheimer's disease. What you're looking at here is a neuritic plaque, and if you remember nothing else, remember this. These are extracellular deposits of beta amyloid protein. Think of beta amyloid like molecular trash that the brain forgot to take out. Normally, proteins get broken down and cleared efficiently, but in Alzheimer's disease, beta amyloid fragments clump together and accumulate between neurons. Over time, they interfere with synaptic communication, and neurons are a little dramatic when communication fails. They don't just struggle, they die. Histologically, notice the dense central amyloid core, surrounding dystrophic neurites, reactive astrocytes and microglia. Your brain is basically mounting a tiny inflammatory protest around this junk pile. Histotech tip: these plaques are much easier to highlight with special stains such as Congo red, thioflavin S, and immunohistochemistry for beta amyloid. But let's be honest, on H&E they can be subtle, and subtle is not what we want at 2 a.m. during a long embedding shift. Some worthless knowledge that might win you trivia night: beta amyloid is derived from a protein called APP, amyloid precursor protein, which sounds harmless until it absolutely is not. Okay, let's talk about the intracellular villain. If plaques are the garbage between the houses, tangles are when the structure beams inside the house collapse. Neurofibrillar tangles are composed of hyperphosphorylated tau protein. Tau normally stabilizes microtubules, the internal transport highways of neurons. When tau becomes abnormal, microtubules fall apart, nutrient transports fail, and the neuron essentially starves. Game over. Histologically, you'll see flame-shaped or twisted fibrillary structures inside neurons, and once again, neuron death follows. Many researchers believe tau burden correlates more closely with cognitive decline than amyloid load. So plaques may start the fire, but tangles burn down the house. Silver stains historically highlighted tangles beautifully. Yes, silver stains. But pathology is nothing if not dramatic. This slide is a favorite for teaching because it shows pathology in a way that punches you right in the clinical empathy. Look at the difference. Healthy brain. We have a thick cortex, tight gyri, narrow sulci, nice and plump. Exactly what we want in brain tissue, nowhere else. Severe Alzheimer brain, we have cortical atrophy, widened sulci, a narrow gyri, and enlarged ventricles. The brain is literally shrinking. And remember, the skull does not, so the extra space fills with CSF. This atrophy correlates with memory loss, personality changes, executive dysfunction, and loss of independence. This is why Alzheimer's disease is not just a diagnosis, it is a family disease. When grossing brains like this, always appreciate the weight and measurements. Numbers matter. Pathology loves receipts. Now shifting gears from cognition to movement, Parkinson's disease is a dopaminergic neuron problem, primarily affecting the substantia nigra. And yes, that translates to black substance. Once you see a normal one, you never forget it. In Parkinson's disease, that pigment fades because the neurons producing dopamine are degenerating. Classic clinical signs, remember TRAP, T-R-A-P, tremor, rigidity, akinesia or bradykinesia, and postural instability, or as I like to say, when your basal ganglia stop cooperating. We have the L-DOPA response, so patients often improve with L-DOPA, which replenishes dopamine, but it does not stop the neurodegeneration. It just helps the surviving neurons work harder. Honestly, the overachievers of the central nervous system. Microscopic hallmark, we'll see Lewy bodies. These are intracytoplasmic inclusions made largely of alpha-synuclein. If tau is the villain in Alzheimer's disease, alpha-synuclein is the troublemaker here. Histotech insight, pigment loss can sometimes be appreciated even during gross examination of the midbrain. Yes, gross pathology is still cool. Do not let anyone convince you otherwise. All right, so let's talk about one of the coolest name structures in the brain, the substantia nigra, which literally translates to black substance. And honestly, neuroanatomists were not being poetic. It really does look darker. That dark coloration comes from neuromelanin, a pigment found inside dopamine-producing neurons. Now here is where pathology enters the chat. In Parkinson's disease, those pigmented neurons degenerate and die, which means that dark band fades away. Grossly, what you're seeing here is exactly that, loss of pigment. Think of it like walking into a dense forest that used to be full of tall, dark trees, and now it looks suspiciously sparse. Not great. Microscopically, you would expect to see loss of dopaminergic neurons, gliosis filling in the gaps, and possible Lewy bodies within surviving neurons. Lewy bodies are intracellular inclusions made largely of alpha-synuclein, and when proteins start aggregating inside neurons, it is basically the cellular version of hoarding. Neurons are minimalists. They do not tolerate clutter well, and functionally, losing dopamine disrupts motor circuits, which is why patients develop tremor, rigidity, and bradykinesia. The takeaway? Pigment loss here is not cosmetic. It reflects neuronal death. Now we shift gears into another neurodegenerative disorder, but with a very different mechanism. Huntington disease is autosomal dominant, meaning only one mutated allele is needed. Unfortunately, it also means the mutation tends to march through generations with uncomfortable predictability. The mutation involves a CAG trinucleotide repeat expansion in the Huntington gene. More repeats equal earlier onset. Genetics can be brutally efficient. Which structures are hit the hardest? Well, primarily the caudate nucleus, the putamen. Together, these form part of the basal ganglia, which help regulate movement. When neurons here die, the brain loses its ability to fine-tune motion. Instead of smooth, coordinated activity, movements become rapid, jerky, and dance-like, a phenomenon called chorea. Fun fact, chorea comes from the Greek word for dance. Less fun reality, this is not choreography anyone signed up for. Histologic expectations, we have marked neuronal loss, reactive gliosis, and atrophy of the stratum. Grossly, the caudate actually shrinks enough that the lateral ventricles appear enlarged. Important reminder, when ventricles look bigger, always ask yourself, is CSF increasing or is brain tissue disappearing? Often it is the latter. ALS targets something extremely important, the motor neurons. Both upper motor neurons and lower motor neurons. So the brain and spinal cord lose the ability to communicate effectively with skeletal muscle. Imagine trying to run a group chat where half the participants suddenly lose signal. Messages stop getting through. Muscles no longer receive stimulation, so they atrophy. Gross pathology. The spinal cord will show thinning, reflecting degeneration of motor tracts. And microscopically, you would expect loss of anterior horn cells, gliosis, degeneration of the corticospinal tracts. Sometimes you can see cytoplasmic inclusions such as the Bunina bodies, which are tiny but diagnostically helpful. Now, the cause, still not fully understood in most cases, which for scientists is basically the equivalent of an unsolved mystery novel. ALS progressively impacts movement, but typically spares cognition early on, meaning patients remain very aware of what is happening. And that is part of what makes this disease especially devastating. Okay. Now this image is showing us sections of the spinal cord, not muscle. And what you should immediately notice is that the cord appears thinner than expected, almost a little deflated. That is not artifact, that is atrophy. What is causing it? Probably ALS leads to degeneration of the upper motor neuron tracts, especially the corticospinal tracts, and then the lower motor neurons in the anterior horns. So when neurons die, tissue volume shrinks. The nervous system follows the classic pathology rule, use it or lose it. If we zoomed in microscopically, we would expect to see loss of anterior horn cells, gliosis replacing dead neurons, and pallor of the lateral columns from corticospinal tract degeneration. Pallor is one of those pathology words that really just means something that used to stain nicely doesn't anymore. Always suspicious and always important. Why this matters clinically, remember, the spinal cord is the major highway for motor signaling. When those tracts degenerate, the brain and the muscle communication breaks down. Muscles are technically fine at first, but without neural input, they begin to atrophy. So muscle wasting in ALS is actually secondary to neuron loss, not a primary muscle disease. Huge distinction. Histotechnologists who understand that mechanism become much stronger interpreters of tissue. Some quick humor. Think of motor neurons like Wi-Fi routers. If the router dies, your laptop is not broken, your signal is. ALS is essentially a progressive system-wide connectivity failure. Not funny for patients, but memorable for learning. Immemorable equals sticky knowledge. Whenever you see central nervous tissue shrinking, ask yourself, is this developmental, is this vascular, or is this degenerative? In this case, textbook neurodegeneration. Okay, let's talk about something your neurons definitely do not RSVP yes to, which is chronic alcohol exposure. Alcohol is a central nervous system depressant, meaning it slows down neuronal firing. Think of it like turning the brain's dimmer switch down, sometimes way down. Clinically, we see slowed cognition, impaired reflexes, and decreased motor coordination, which explains why "I'm totally fine to drive" is almost always incorrect. Now for a little physiology crossover. Alcohol suppresses antidiuretic hormone, ADH. Less ADH is more water excreted and dehydration. Fun fact, that pounding headache after heavy drinking, not just poor life choices. Your brain literally shrinks slightly from dehydration and pulls on the meninges. Pain receptors say hello. Chronic exposure is where histology gets interesting. You may see cerebellar degeneration, so especially loss of Purkinje cells, cortical atrophy, and enlarged ventricles. Grossly, the brain can look smaller with widened sulci. Another major concern, cardiac conduction disturbances. So electrolyte imbalance plus toxic effects on myocardium equals arrhythmia risk. So yes, alcohol affects more than just neurons. Primary brain tumors are relatively uncommon compared to metastasis, but when they occur, histology is everything for classification. Most originate from glial cells. So remember, neurons rarely divide, and glial cells absolutely do, which makes them prime tumor candidates. The major gliomas, we have astrocytoma, which is derived from astrocytes, the CNS support staff. Oligodendroglioma, which is think fried egg cells on histology, round nuclei with clear halos. And then we have the ependymoma, often shows perivascular pseudorosettes. Tumor cells arranged around blood vessels like they're forming a tiny cellular wreath. And then there's also glioblastoma, the heavyweight champion of aggressiveness. Features include necrosis, pseudopalisading cells, microvascular proliferation. And so translation, it's fast-growing and destructive. Other tumors worth knowing is medulloblastoma. It's common in children, highly cellular small blue tumor. Meningioma, which is usually benign, often compress rather than invade. Cranial and spinal nerve tumors, examples would be schwannomas and, of course, metastasis, the frequent flyers, most commonly from lung, breast, melanoma, and kidney. The brain is actually a very popular metastatic destination because it receives about 15 to 20% of cardiac output. So lots of blood flow equals lots of opportunities for circulating tumor cells. What you're looking at here is a classic example of a tumor that says, I'm not touching you, but I am squishing you. Meningiomas arise from arachnoid cap cells, typically benign, slow growing, but space inside the skull is extremely limited, so even polite tumors cause problems. Grossly, they appear well circumscribed, firm, and often attached to dura, sometimes described as having a rubber ball consistency. Histology hallmarks, they're whorled cell patterns in the psammoma bodies, which are calcified concentric structures. Fun fact, psammoma bodies look like microscopic tree rings, pathology's version of dendrochronology. Symptoms are usually from compression, so headaches, seizures, focal neurologic deficits, and location determines presentation. Good surgical candidates in many cases, which is always nice to see. Now, we shift gears to end this on a tumor that is far less polite. The medulloblastoma is a highly malignant cerebellar tumor, most commonly seen in children. Grossly, it's soft, gray-white, and often located in the midline cerebellum, which can obstruct CSF flow and cause hydrocephalus. Histologically, you'll see dense sheets of small blue cells, high nuclear to cytoplasmic ratio, and frequent mitoses, sometimes forming Homer-Wright rosettes, tumor cells that are arranged around neuropil. Not a true lumen, just organized chaos. Clinical tie-in, because it loves CSF pathways, it can spread through the ventricular system. Pathologists sometimes call these drop metastases, not the kind of dropping we enjoy. Some worthless knowledge, the medulloblastoma is one of the earliest tumors successfully treated with combined surgery and radiation protocols, a big historical win in neuro-oncology. Okay, and that wraps up the CNS section beautifully. If there is one big takeaway from all these slides, it's this. In the brain, location matters just as much as pathology, and histology is often the final word on diagnosis. Also, your brain after this lecture is significantly more wrinkled, but in a good way.